Good day, everyone. Today I'll be speaking to you about anesthesia for geriatric patients. So, the outline of this presentation is that we will start with the introduction. We'll look at the physiology of normal aging, pharmacokinetics and pharmacodynamics. We will also look at the anesthetic considerations and finally the conclusion. So, who is the elderly patient? This is a patient that is greater than 65 years, basically 65 years and above. And typically, these patients are said to be homeostenotic. So, the term homeostenotic means that they have a reduced physiological reserve and they have um, issues with maintaining normal homeostasis. So, if we look at the global distribution of the elderly, we find that in 2015, uh, we had a percentage of about 7% of the population was elderly in Africa, because I'm mainly based in Africa. And in the first world, it was about 14 to about 20%. And then in 2050, it is projected that a third of the population will be elderly in the developed world. And in our region, it will be just over 10%. So that's a substantial amount of people that are going to be elderly at that point. Also, looking at this global population pyramid, we see that the percentage of elderly people is progressively increasing from 1970 all the way up to 2016. And according to the United Nations, by year 2050, there will be more elderly persons than children under the age of 15. So, looking at the physiology of normal aging, starting with the cardiovascular system, because as anesthetists, our main focus is the cardiovascular system, the respiratory system, and the neurological system. This is not to say that other systems are not important, but our main focus as anesthetists is that mainly to the cardiovascular and respiratory system. So, we'll start with those. So, looking at the cardiovascular system, it's not uncommon for elderly patients to develop arrhythmias, and in particular, they might develop ectopic beats, and these are just innocent. And when you connect them up to the ECG on your operating room monitor, you might pick up occasional ectopic beats. This is nothing to really worry about. It's part of the physiology of normal aging. However, if you have multiple ectopic beats, then that may be a point of concern. You may need to contact or get a cardiology consult for those patients, because if they've got multiple ectopic beats, there is a risk that they can develop uh, things like an AF on the table during surgery or under anesthesia, and that is can be potentially life-threatening. But otherwise, most of the time, these patients have um, things like ectopic beats, mainly ventricular ectopics, which you should not really worry about. And what I've also found is that under general anesthetic, especially with volatiles, you find that the rhythm can actually improve. So those ectopic beats can quote unquote disappear under general anesthesia. Elderly patients also can have valvular issues. Sometimes their valves can become calcified, and what is mainly of concern with these valves is patients who then develop things like aortic stenosis. And we know that aortic stenosis is one of the contraindications of a spinal. I know it can be a point of controversy, but we have found that and in our practice, generally, aortic stenosis is a contraindication for a spinal, um, especially if the patients are symptomatic. then it becomes can become a big issue. So it's important to think about that. Then left ventricular hypertrophy can occur in these patients. This is due to the fact that there is increased afterload and the heart is pumping against blood vessels that are stiffened. So then what then happens is they develop concentric hypertrophy of the left ventricle as a result of the stiffening of the blood vessels in the circulation, in the systemic circulation. Elderly patients can also have diastolic dysfunction, so it's very important that when they're under anesthesia, you try and maintain their heart rates to low normal so that they have enough time for coronary filling and also to make sure that the left ventricle has time for filling. So I was explaining to one of the trainees that in the cardiac cycle, diastole is the plays the bigger part. It's about 2/3, and systole is about 1/3. So you actually need you need to make sure that the heart actually has enough time during diastole because many things are going on during that phase. That's the time you get coronary filling of the coronary supplying the left ventricle, and also it gives you the heart time to fill the left ventricle as well. And some of these patients have got diastolic dysfunction, so they actually rely also on what we call the atrial kick. So they need that volume of blood that is in the atria in order to be able to have an adequate cardiac output. And that's why it's very important that their heart rates are low normal and they don't go into atrial fibrillation. Because once they're going to, if they have a fast heart rate or they're tachycardic or they have atrial fibrillation, then they lose that atrial kick and that can put them at risk of myocardial ischemia and also impaired perfusion to other organs in the body. They've got impaired baroreceptor reflexes, so if they become hypotensive, they will not be able to mount that compensatory tachycardia like in a young patient. So this patients, it's very important that you make sure that they are fluid replete when they're coming in for surgery because they rely on their preload. Another important thing as well is they've got decreased beta receptor sensitivity. So if you need to give them agents like ephedrine, you need to give them a higher dose because their beta receptors are not as sensitive to sympathomimetics. You definitely need a higher dose. The vasculature tends to be more stiffened, so they develop chronic hypertension. That's what I mentioned. And also as a result of that, they will also eventually develop LV hypertrophy. This is a summary page from an article by Conondio Caristiano, published in 2007. I just put it here because I found it's very helpful to explain most of the things I was alluding to. So elderly patients will have an elevated afterload, mentioned that elevated systolic blood pressure, left ventricular hypertrophy, decreased atrial elasticity, decreased heart rate, and decreased baroreceptor reflex. On the right side of this table shows the conditions that they may possibly develop. So elderly patients can develop these conditions. These are actually pathological conditions. They're not part of the physiology of normal aging, but it's important to know that elderly patients can present with hypertension. They can have coronary artery disease. They might have congestive heart failure. Uh, then moving on to the respiratory system. So elderly patients can have undiagnosed obstructive sleep apnea. So they may not be aware that they actually have obstructive sleep apnea. And the sleep apnea occurs due to an increased fat accumulation around the airway. And that can cause obstruction of the airway, and then they can end up having OSA, especially when they are sleeping, they may end up snoring. They also have decreased chest wall compliance, so the chest wall tends to be much stiffer. On the other hand, they have increased FRC due to an increase in the residual volume. The increase in the residual volume is because they have some element of air trapping because they're unable to completely exhale. So some of the air gets trapped inside the lungs, and that then causes the FRC to increase. So for us as anesthetists, that's not a bad thing that we've got an increased FRC because it means that when we taking these patients to the operating room, we induce them, well, after we've pre-oxygenated them, it means that our apneic time is actually going to be prolonged. So for us, that's not such a bad thing at all. They have a decreased vital capacity with an increased closing capacity of the alveoli, which leads to atelectasis. Well, that is undesirable because it puts them at a risk of atelectasis. And then they get impaired responses to hypercapnia and hypoxemia, which is very important. So elderly patients will not respond the same way as a young patient would in the presence of an increased CO2 or decreased O2 saturation in their blood. So their response will be different. In fact, the partial pressure of oxygen of the blood in the elderly patients is lower than your healthy young patient. So that's important to note. Moving on again with the physiology of normal aging. So the neurological system, some of the patients may have some element of cognitive impairment, and it's important to note that. And also still with the neurological system, um, because of wear and tear, these patients are at a high risk of peripheral nerve injury. So it's very important when you are positioning them in the operating room to make sure that the pressure points are protected because these are the patients that are at high risk of developing nerve injuries. In terms of the renal system, the glomerular filtrate rate is reduced. They've decreased ability to handle sodium and water load. They've an increased susceptibility to nephrotoxic agents. So if you need to give them any drug which may potentially be nephrotoxic, you must have a valid reason for doing that, and the benefits should outweigh the risks. And the hepatic system, the liver mass is reduced and the liver function is reduced. And that means anesthetic drugs that are metabolized by the liver will tend to, their effects will be prolonged. And the albumin levels are also decreased, which means anesthetic drugs that are protein bound will be circulating in the body for longer because you've got more free drug available. One example is local anesthetics. So elderly patients are at high risk of local anesthetic systemic toxicity simply because some of the local anesthetics that we give are protein bound and because the albumin levels are lower. So if you're giving them local anesthetics as probably as an infusion in a catheter, or you are running maybe a lidocaine infusion IV, you need to bear that in mind that these patients might bear the risk of developing local anesthetic systemic toxicity simply because they've got a decreased albumin levels, and also the fact also that their livers are their liver function was decreased, so they'll also not be able to metabolize the local anesthetic as quick as the young healthy patient. Looking at pharmacokinetics, so the mnemonic or the memory aid we often are taught in medical school is ADME, which stands for absorption, distribution, metabolism, and excretion. So the elderly patients have got a decreased total body water and muscle mass, so most of them tend to be sarcopenic, and because of that, this leads to a lower central compartment volume and a higher initial plasma concentration. The increased body fat leads to larger volume of distribution for lipid-soluble drugs with slow release from this relatively large adipose reservoir that prolongs clinical drug effect. They have a decreased glomerular filtrate, which leads to an increased plasma concentration of renally excreted drugs. They have slower metabolism of drugs by the liver, leading to prolongation of clinical drug effect. The decreased albumin levels that I mentioned lead to large free drug concentrations of highly protein bound drugs. Moving on to the pharmacodynamics, elderly patients are sensitive to anesthetic drugs, and injudicious use of anesthetic drugs can lead to cardiovascular embarrassment, delayed emergence, and other post op complications. So, we have to be careful of our drug doses and how fast we administer those drugs to the patients. So this is a table which was compiled by Canonidu and Caristianu in 2007 in their article. I included this because I felt it was very helpful. So when we look at the elderly patients, they are quite sensitive to inhaled uh, agents, and inhaled agents, we're talking about volatile anesthetics. So according to literature, uh, MAC requirements decrease by 6% every 10 years uh, after the age of 40. So you need to bear that in mind. So elderly patients don't need as much volatile as a young patient who is like 20 years of age. So you need to reduce your volatile requirements for these patients. And an easy way to do that is to key in the patient's age if your machine does allow it, and it can calculate for you what the MAC requirements are. And putting the patients on ET volatile control mode will allow the machine to deliver a set concentration so that you don't over, quote unquote, over anesthetize the patient. Thiopental was a drug we used to use. I've been exposed to it, but it's no longer available. They're not as sensitive to that one, but you have to reduce the drug dose if you're going to use it. Etomidate, similar to thiopentin, in that they are not as sensitive to that one, but you still have to reduce the drug dose. Propofol is interesting. So with propofol, they are sensitive to propofol. In fact, propofol can cause profound decrease in blood pressure in elderly patients. Typically, what happens is that after you administer the propofol, it will seem like the patient is reasonably stable, but then the hypotension occurs about 6 to 8 minutes following the administration of the propofol, and the blood pressures can plummet substantially, especially if the patient is dehydrated uh, or there is concomitant use of high concentrations of volatile after induction. Then it's very important that when using propofol for induction, you halve the dose and you give the propofol in small increments. In fact, you titrate it to the clinical effect, checking your patient, speaking to your patient, and ideally, if you've got a depth of anesthesia monitor, that will be more helpful and will help you to avoid giving an excessive amount of propofol. Midazolam, they're also quite sensitive to midazolam. We prefer not to give midazolam to the elderly patients because it can cause post-op delirium. Morphine, they are sensitive to it, so you actually have to reduce the amount of propofol, morphine that you're going to give in these patients. Remifentanil, they are also particularly sensitive to remifentanil, and the important thing you need to know about remifentanil is that remifentanil can cause bradycardia and profound hypotension. So if you intend on running a remifentanil infusion intra-op for these patients, it's prudent to run a concomitant infusion of phenylephrine so that you maintain their blood pressures within normal limits. Again, you have to reduce your remifentanil dose. You cannot give the same dose that you give in a young patient because it will cause profound hypotension, bradycardia, and these patients can also develop chest wall rigidity. So you need to be aware of that. When it comes to drugs like atracurium, cisatracurium, these drugs undergo Hoffman degradation. There isn't an increased sensitivity to these drugs, and you don't necessarily have to reduce the doses that you're going to give them because they are independent of liver and kidney metabolism. Other drugs that you need to be thinking about, these are the drugs that you want to avoid. So we talked about drugs that are commonly used in anesthesia, but these ones may not be commonly used, but may sometimes be used for our patients in the perioperative setting. So that's why I included them. So drugs like metoclopramide, which is an anti-emetic drug, because it has an effect on the dopamine receptors, it's undesirable in the elderly. Similar to haloperidol, an antipsychotic drug also acting on the dopamine receptors. The problem with these drugs is that they can cause the patients to develop issues with their muscles, so they can precipitate like a leptic malignant type of syndrome. They can have dystonia. So these drugs are really undesirable in the elderly population. So if you want to give them an antiemetic, it's better to give them ondansetron. That's a better drug to give in these patients. And other drugs as well that are of concern are pethidine. Pethidine it's a synthetic opioid, also known as meperidine in the United States. It's undesirable because it is converted into norpethidine or norpethidine, which is epileptogenic. So that is undesirable, and it also tends to make can cause the patient to become profoundly sedated, especially in the elderly patients, with very minimal analgesic effect. And Benadryl also not great in the elderly patients, can precipitate delirium. Same thing with benzodiazepines, delirium, and scopolamine, atropine. These are anticholinergic drugs. Um, they are not great for the elderly patients because they also cross, like for example, atropine will cross the blood-brain barrier, and it can precipitate issues like delirium. So these are drugs that you should avoid in the elderly if possible. Then moving on to our anesthetic considerations. So when you see the elderly patient, the important thing that you need to do is to take a focused history in a medical examination. You need to also make sure that you establish what chronic diseases or conditions that the patient has, because all of those conditions need to be optimized for surgery. So if a patient is diabetic, you need to find out from the patient what the patient is being managed on. Is the patient on insulin? Is the patient on oral hypoglycemics? And then you need to give appropriate instructions of what needs to be done for blood glucose control in the perioperative setting. For example, if a patient is on insulin, we always advise them not to take the insulin on the day of surgery because it's going to cause profound hypoglycemia. So those are some of the things that you need to discuss. And with the chronic conditions comes the medications. So that's a very important thing. Most of the time, elderly patients might have polypharmacy, and you need to take the time to go through each and every drug that the patient is on. And if you do not know the drug, you need to look it up and determine or find out how that particular drug may potentially interfere with your anesthetic drugs and the patient's condition perioperatively. And then after you have gone through all the medications, you need to give feedback to the patient as to which drugs they should take and which drugs they should not take uh, on the day of surgery. Sometimes it is very helpful to speak to whoever a relative who comes with the patient or a caregiver of the patient and communicate these important details to them. Because sometimes our elderly patients may not remember finer details and they may struggle to remember everything that you say in the consult. So it's always good to have somebody else handle that information. And it's important that uh, that person reports back to you what you have said so that you are confident that they have fully understood what needs to be done in terms of the medication. Then in the pre-op setting as well, we want to optimize the HP. So there is evidence that when elderly patients come in for surgery, if they are operated with low HBs, and we're talking about hemoglobin of 8 grams per deciliter or 80 uh, yeah, we're talking about 8 grams per deciliter. So if it's less than that, there is a risk that these patients may have increased morbidity and mortality when they have low HP. So with the low HP, it's not about trying to give them blood products. That's not what we're trying to do. We're not trying to transfuse them. But in the pre-op setting, what we want to do is to optimize the red cell mass according to the pillars of blood management, so that prior to surgery, we can optimize their HP. Then we need to assess for frailty because how frail a patient is can actually affect the surgical outcomes. And we also need to assess the patient's baseline cognitive function. This is not often done by some anesthesiologists, but it's very, very important. So one can do a mini mental state exam, and if you're not too sure of how to do it, you can always ask your psychiatry or psychiatric colleagues to help us with doing these tests for our patients. So on the next slide, I've included a frailty scale. This is from the Dalhousie University. There are other frailty, clinical frailty scales that are out there, but this is one that I have used quite frequently. So there is a difference in terms of frailty. So frailty basically speaks to uh, the ability or the resilience that a patient has after having had maybe a surgical intervention. So we are saying that if this patient undergoes surgery, which does cause an alteration in their normal physiology, do they have enough reserve to bounce back? So if your patient is frail, it will be very, if a patient is severely frail, like you're looking at someone on this scale who's on 9, after major surgery, they may have difficulty going back to their normal state of function. And there is a big difference between a patient who is sitting on a scale of 8 and a patient who is on a scale of like 4. So the patient who is on 8 is a patient living with severe frailty. This is a patient, as you can see in the picture, is in bed, probably spends quite a lot of their time in bed. And the patient who is on the scale of 4 is a patient living with mild frailty. They use a walking stick. This type of patient is more likely to have a better outcome than a patient who is bedridden. So that's why it's important to assess for this. And there is a correlation between poor outcomes and the frailty scale. So it's important to actually give a report or write in your notes or type in your notes where you kind of assess where your patient is on the frailty scale. All right, then moving on to investigations. So investigations are always important as part of our pre-op assessment. So according to the guidelines, and most of the information I've gathered in this presentation is based on an article on Up to Date, which was published in this very year. It was updated in the month of May 2025 at the time of making this presentation. So what the author said in the article and Up to Date is that there is no clear consensus as to what blood tests need to be done. So in my time when I was and my colleagues were trainees in anesthesia, we always kind of had this batch of tests we would do for our elderly patients. So we'd always tell the surgeon, we need a chest x-ray, we need an ECG, we need an echo, we need baseline bloods. It was kind of standard for the elderly patient. But the evidence says that now there is um, there's no reason actually to do all those batch of tests because it's actually a waste of resources. Um, you really need to have a strong reason to do it. Your strong reason is based on the patient's physical health status, your clinical examination, the type of surgery. So, if, for example, a patient is going in for a bleeding operation, no patient is going to bleed. then at least we need to know what the patient's baseline hemoglobin is and what maybe the platelets are. So those are the things that you look at. An ECG is not routine, only request for an ECG if there is an underlying cardiac issue or you suspect a cardiac issue, or if the patient has got some form of vascular disease, like for example, they've got peripheral vascular disease, they've got critical limb ischemia, those are the patients that would need an ECG. But it shouldn't be routine for every single elderly patient. Same thing for X-ray. So chest X-ray is not should not be routine. There must be a reason why you're ordering a chest X-ray, and it's only indicated if the patient has got some issues with their heart, like a cardiac condition or a pulmonary condition, or if they're coming in for a cardiothoracic procedure, then there would be an indication for a chest X-ray. For the part of the pre-op assessment, a multidisciplinary team may be needed, may be required, but it is not routine. So there has to be a reason why you are involving a multidisciplinary team. So there has been evidence to show that multiple or several investigations don't actually affect the outcome. So there was a study performed where they looked at patients coming in, I think it was eye surgery. They had one group had a lot of investigations done, and the other group actually didn't have much. The outcomes were generally the same. So there is actually no need to subject patients to all sorts of investigations when they are not required. And the other thing, it also leads to wastage of resources. So, general anesthetic versus regional, which is best for the elderly patient? So, in a study, randomized trial by Vale et al. Published in Anesthesiology last year, 2024, and also in a study by Newman et al. In the New England Journal of Medicine, published in 2021, they looked at elderly patients coming in for orthopedic procedures, and I think in particular it was hip surgery. In terms of long-term outcomes, there wasn't any difference between patients. There wasn't any clinically significant difference between patients who had general and patients who had regional anesthesia. So there isn't much difference. However, in my clinical setting, because most of my anesthetic practice was in a low resource setting, South Africa in the Eastern Cape, we found that neuraxial anesthesia combined with peripheral nerve blocks were much better for our setting because most of the time the people looking after these elderly patients are junior. These may be people, maybe doctors who are working towards a diploma in anesthesia, so they do not have much experience in managing elderly patients, especially when it relates to their airways and their hemodynamics. So it's much safer for them and easier for them to perform a spinal if it's not contraindicated, followed by a peripheral nerve block if it is indicated, and then to proceed thereafter with a conscious sedation. Uh, the reason being that this type of technique avoids airway instrumentation, it obviates perioperative respiratory adverse events that relate to hypoxia, laryngospasm, atelectasis, aspiration, and also it obviates the complications associated with hemodynamic compromise that can potentially occur at the time of induction and intra-op in this patient group. What we also found is that in terms of hospital stay, it's reduced when patients have a neuraxial technique and a peripheral nerve block because their pain tends to be much better controlled. There's less use of opioids and less pulmonary complications and better patient satisfaction. So in our setting, we tend to go for regional anesthesia, firstly because it's safer for us and we have better patient satisfaction. However, in bigger centers or in the developed region of the world, A general anesthetic is definitely not a bad idea, especially if the patient has refuses to have an uraxial technique, because there are so many resources. Patients have got many analgesic options available to them, so a general anesthetic will probably not a bad thing to go for them. And also there probably is more expertise in terms of managing airway, a greater array of airway devices and resources to manage those patients. So pre-induction is always important to have, make sure you've got good IV access. Take time to actually locate a good vessel which you're going to cannulate to reduce the chances of fluid extravasation. And as I mentioned, there's no need to pre-medicate these patients. Giving them midazolam only increases the risk of post-op delirium. So I just added these photos in just to show you the challenges of cannulating an elderly patient. And I'm sure if you have been practicing anesthesia for a number of years, you totally agree with what I'm talking about. So, because this patient's veins can be quite difficult sometimes, might be able to see the vein, you try to cannulate it, and then it just blows up, and the patients end up developing these bruises. The other thing as well is that their veins may actually be tortuous. So when you want to cannulate these patients, always try to get a good caliber vein that is straight, almost like this one. And also, sometimes their veins can roll, so it's always good to make sure you support or help in a way of fixing the vein so that it doesn't roll as you puncture it. Uh, because if you don't do that, you're going to end up in this scenario where you're going to end up pricking the patient a lot of times, and the patient is not going to be happy with you. It's also very important to make sure that you have a good, a good enough cannula that's big enough for the type of surgery that you're doing. So it doesn't help to put in a blue cannula, which is a 23 gauge, to avoid causing trauma to the patient or causing anxiety in the patient. And then when you get into the OR, you struggle to actually run fluids through that cannula, or you struggle to resuscitate the patient because you're trying to resuscitate the patient through a very small cannula. So that is counterproductive. So try and make sure that when you're trying to put in a cannula on a patient, at least start with the 20 gauge, if that's all you can do. Start with a 20 gauge, which is the pink cannula. And once the patient is asleep, that's an anesthetic where you're going to do a GA. Look for another line if you need to. If it's a spinal, I would advise going for an 18 gauge, because sometimes with spinals, these patients can become hypotensive, and you want to make sure that you've got a freely running line and you want to get fluid in as soon as possible. So these elderly patients, as we mentioned, they have poor baroreceptor reflexes, and they will not respond the same way as a young patient to hypotension. They will not cope uh, well with hypotension. And one of the reasons why they don't cope well is because they rely on their preload. So if you're going to administer an anesthetic or general anesthesia if you're going to administer a spinal or general anesthesia to these patients, you should always make sure that they are fluid replete, because when you attach the monitors, it might seem that the patient is okay, but once you administer propofol and volatile anesthetics, the blood pressures can plummet rapidly, and the patient may suffer cardiovascular embarrassment. And as one anesthetist says, the blood pressures will go all the way down to the floor, and you'll be struggling to get them up again. So it's important to assess the patient's fluid status. How do you do this? You can check clinically, so you can examine the patient, feel for the pulses, and also assess the mucosa, the oral mucosa, to see if it's dry or not. Um, what I tend to do is prefer to do bedside echo, but that requires a certain level of skill. We are as anesthesiologists or anesthetists, we are not cardiologists. However, we do use echocardiography in the perioperative setting to guide fluid administration and also to guide us in when we perform resuscitations. So if you have some bit of echo exposure, this is when it becomes quite handy. So as anesthetists, we don't make diagnoses. We don't tell patients those big cardiology diagnoses. However, we can eyeball, so we're able to see how the patient's fluid status is. We can see if a heart is failing or not, just by what we call eyeballing. Okay. So this is a patient that we saw in our hospital. So the first view on the left, this is what we call the parasternal long axis view. So what does it show us? It shows us the left ventricle here, and we've got the intraventricular septum, right ventricular outlet tract, and we've got the left atrium here. Here we've got the mitral valve. So what we can appreciate in this patient is that we've got poor LV contractility. Okay. And then on the right, we have the parasternal short axis view. And what we can see also is that there's poor LV contractility. So this is the LV and this is the right ventricle. So we can see this poor left ventricular contractility. And this is at the level of the papillaries. So what we can say is this from a fluid status. So this patient, because this patient's got poor LV contractility, this is a patient that you have to be careful of in terms of your fluid administration. If you give them too much fluid, they can easily go into heart failure. So you don't want to do that. So if I was going to anesthetize this patient, I would be very careful about fluid administration, and I would also make sure that I put in an arterial line in this patient prior to induction, because I would be very careful about this patient. I would want to know what the beat to beat blood pressures are. And in addition to that, I would also use monitors that would show me changes in terms of things like systolic pressure variation to guide me in terms of my fluid administration in this patient. Okay, so that's when bedside echo can be helpful. So this is not the only case that we've picked up. So there are other patients who were quote unquote fairly healthy, but who presented uh, in a state of dehydration because they had undergone a prolonged fasting period. And just by putting the echo or the probe onto the chest, we're able to see if the patient is fluid depleted. So if they're fluid depleted, you'll find there is that kissing, what we call the kissing sign, where the left ventricle, the parts of the left ventricle, the walls of the left ventricle are kind of kissing. Or you also see the collapsing of the IVC, which would tell you that the patient is fluid depleted. And then you'd need to give some fluid. So that really helps a lot, and it helps you to help in your clinical decision making, and it helps you to give a safer anesthetic. All right, so at induction, these patients, you have to go slow, because if you go fast, they are going to become profoundly hypotensive. So you need to give half the induction dose, that's propofol, and you need to think about blunting the intubation response. However way you do it, you can use alfentanil, remifentanil, and fentanyl. So you have to go slow and you have to blunt intubation response, because these elderly patients are already hypertensive, and once you perform laryngoscopy, the blood pressures can go right through the roof. But prior to you giving the induction agents, you must always pre-oxygenate your patients, and at that time, that's when you start considering things like mask ventilation. So these elderly patients can be difficult to mask ventilate, and for several reasons. I had one patient coming into the pre-admission clinic who had a very thick beard. In fact, I've had two, but a very thick beard. And they were both of them were adamant in that they will not cut their beards. And this was not for religious reasons. It was because they were all, both of them were actually it was on different instances, but both of them were Father Christmas. They told me they're Father Christmas. They do that for a living. They cannot cut their beards because it would mean they're going to lose their living. So they cannot. And despite all the efforts and explaining the fact that when they're under anesthesia, it will be difficult to get a good mask seal and they could possibly lose their lives if we can't ventilate. They were very, very adamant that they could not. One of the patients I was able to convince just to trim his beard. He managed to trim it. It didn't make such a big difference on the day of surgery, but at least it made at least he tried. The other patient was extremely adamant. He would not even trim his beard at all. So you will have those type of patients, and if they present with a beard, it's going to be difficult to mass ventilate because you can't get a good seal. Another thing with elderly patients, I did mention the fact that they might have obstruction. Some of them may develop OSA. Another important thing related to obstruction is that they have the muscles of the airway. They maybe can get affected, especially the muscles that are involved in the upper airway dilation. They can reduce in size, and the result of that, that can cause issues with ventilation. And I think the muscle is the glossal muscle, if I'm not wrong, that's affected. Um, so they might have no teeth. So elderly patients may have no teeth. So it might be difficult to have a good mask seal in those patients. And also, these patients may have facial muscle atrophy. So also it will become difficult to get a good mask seal, and hence it will be difficult to mask ventilate them. So when it comes to laryngoscopy, they may have decreased mouth opening, decreased neck flexion and extension because they might have rheumatoid arthritis of the neck and their neck might be in a fixed position and difficult to mobilize. They might also be at a risk of atlantoaxial subluxation, so it's important not to move their necks up and down. So it's advised to use a video laryngoscope so you avoid excessive manipulation of the head and neck. Front of neck access may become a challenge as well, especially if they have some anterior mass like a thyroid, an enlarged thyroid, so it will become an issue. What I also didn't mention with laryngoscopy is that the epiglottis can tend to be floppy, and this is related to the fact that there is loss of collagen in elastic tissue. So then the epiglottis becomes floppy. So it's advised to use a video laryngoscope in these patients because you might struggle with direct laryngoscopy. So this is a table or a picture that I got from an article by Johnson et al. Published in 2015 in a journal called CIA, which is Clinical Interventions in Aging. And they compared the difference between a young and an elderly patient. So we can see that the young patient has got teeth, but the elderly patient has no teeth. And the mouth opening in the young patient is not the same as the elderly patient. So elderly patients have decreased mouth opening. And also you can see that the neck of the elderly patients tends to be short and stiff. So when you have to perform laryngoscopy, it may be difficult to actually position them properly. So these are the things that you need to think about. And hence why using a video laryngoscope would be ideal and is probably the best thing to do in these patients because it increases your chance of first pass success. So as I mentioned, you're going to pre-oxygenate the patients, and it's also prudent to consider apneic oxygenation, especially if you anticipate a difficult airway, because that will help you to keep the patient oxygenated and it will buy you time if you need help. Maybe if you want to call for help from someone else to come and help you, or you want to move on to your next plan. Like maybe, for example, you struggled to intubate the patient with a direct laryngoscope. You could move on to a VL. And then, or if you're having issues with that, maybe you could then consider fiber optic intubation. And as you move from one part of your plan to the other part, or the next step in terms of your airway management plan, oxygenating the patient throughout that phase helps you. It buys you time so the patient doesn't desaturate. Another important thing to note is that why we really emphasize the use of a video laryngoscope is that in these patients, multiple attempts increase the risk of causing hypertension. So if you try and intubate the patient maybe twice or thrice and you're struggling, there is a high risk that these patients are going to have a profound stimulation through the vagal nerve, and they're going to have the intubation response, and their blood pressures tend to go very high. They can go up to the 200s. So then that's why it's very important to try and get the tube in with the first attempt. Make your first attempt the best attempt. So, in order to make your first attempt the best attempt, you must have the necessary equipment. So, you need to have your conventional equipment, your advanced equipment. So, if I think already that this is going to be difficult airway, I actually just go straight for my advanced equipment. And I like this picture by Johnson and Tal because it helps you also in the thinking process. I know the Difficult Airway Society, they talk about plan A, plan B, plan C as to what you're going to do. But this is a very nice plan in that from the outset, you can actually decide what you're going to use based upon your clinical examination. So if I had a difficult patient, I'm going straight for advanced. Okay. If I have a patient who has got decreased mouth opening, I'm going straight for the specialized. I'm going to use a fiber optic scope to intubate the patient. So this type of setup really, really, really helps, and it helps you to um, zero in on what is most important and use that immediately so that it increases your chance of first pass success. All right, so intra-op, we want to maintain the maps within 20% of baseline, aim for a low to normal heart rate to allow for time for coronary filling. We want to avoid excessive amount of anesthetic. So in order to do that, as I mentioned, we want to make sure that our ventilator is set so that we use ET volatile control mode. Because our MAC requirements are reduced in the elderly patients, we don't want them to be quote unquote over anesthetized. We need to monitor the depth of anesthesia using our monitors like a BIS. You could use a BIS monitor, a SEDline, or an entropy, whatever other depth of anesthesia monitor you have, but you need to use it. Yes, these monitors do have their drawbacks, but at least it definitely makes a difference if you're using one of these monitors as compared to just shooting in the dark, quote unquote, shooting in the dark, or just moving in the dark, hoping that the patient is adequately anesthetized or they're just well anesthetized. Most of the time, the tendency is actually to overshoot, especially with these elderly patients, because with after you've administered the anesthetic, over a couple of minutes to an hour, the volatiles tend to accumulate, so your patient might end up being deeper than what you intended them to be. So that's why we like depth of anesthesia monitoring. And the evidence states that uh, in 40% of patients who develop post-op delirium, uh, um, those patients don't never go back to their pre uh, uh, op cognitive state. So that's a lot. It means that if you have two two out of five patients, if you give an excessive amount of anesthetic and they develop delirium post-op, those patients will never go back to their normal state of mental function that they had prior to the surgery. That's a lot. And post-op delirium and post-op cognitive dysfunction is associated with increased morbidity and mortality. The evidence is out there. And so in order to avoid that, we need to make sure that as anesthetists, we are not over, quote unquote, over anesthetizing our patients. And To avoid that, we need to use depth of anesthesia monitoring. Obviously, there is a fear amongst people that, oh, I don't want my patient to wake up. I don't want my patient to be aware during surgery. But when you're dealing with the elderly patients, the chances of them being aware actually are less when you're just giving your standard anesthetic. In fact, we tend to over anesthetize them. So our depth of anesthesia monitoring, what are we looking at? So we're looking at waveforms that are produced when the patient is asleep that we pick up in the cortical region. And the waveforms that we're mainly interested in when the patient is asleep, or the ones that we want to be able to pick up, our delta and alpha, with delta waves with some alpha oscillation. So we want our patients to, when we put the monitor onto the forehead, we want to pick up delta wave, we want to see delta waves on the monitor, and some alpha oscillations, in between. So our delta waves tend to be they're the low frequency waveforms. That's what we want to see. And they're slow waves. That shows us our patient is asleep. And once our patient begins to wake up, we get higher frequency, low amplitude waveforms, these are gamma waves, which signify that the patient is awake. So this is a bispectral index monitor. Remember, it gives you a dimensionless number. Between 40 to 60 is where you want to be for adequate anesthesia. But obviously, the dimensionless number is not as helpful. So nowadays, people have moved towards what we call DSA, which is digital spectral array, which is what's shown here. Okay, and it shows you there are these what we call a heat map. So the red shows us which waves forms are most prominent, are more representative, or kind of having a greater effect. So what we said is we want to see delta representation and alpha, and that's what we're seeing. So the red part tells us this is what's mostly being picked up by the monitor. And because those are the prominent waveforms, and that's what we're getting. So that tells us that our patient is adequately anesthetized. This is a set line. So the way one looks at it, so the dimensionless number is called the PSI. This one, unlike the BIS, is 40 to 60. With this one is 25 to 50. So that's what the range for an adequate anesthetic level would be. And in this case, our patient is adequately anesthetized because we're at 37, which is between 25 and 50. We're also getting, we can see from the waveforms that we are getting those delta waves, those slow waves that tells us our patient is adequately asleep. When we look at our DSA, we also are seeing something similar that we saw on the BIS monitor. We're getting the delta waves coming through. We're also getting those alpha representation as well. So our patient is asleep. The difference here, though, is that there is much more that you can analyze on a set line than your BIS monitor. And also, we are seeing both hemispheres on this one, or cortical region, but we're seeing both the right and the left. And that's represented by the letters here, R and L, whereas the previous monitor, we're only seeing one waveform. There are BIS monitors where you can see both, but that particular one, it's only showing one strip of the DSA. That's not to say it's not monitoring the patient well. It is, and you can use it quite effectively. Okay, so our patient here is adequately anesthetized. Okay. This one is a case where the patient, I think in this case, the patient coughed for some reason, and I had to give a bolus of propofol because the surgeons were in the middle of surgery. So you can see what happened where the sharp rise in the PSI, and suddenly there was a dip there, and the number went down. Remember, I said 25 to 50. This patient is at 21, and you can also see that the waveforms are much flatter. It's almost like the patient was going into like burst suppression because I gave a bolus of propofol just to deepen the patient. So Ideally, we do not want our patients to be at this level for a prolonged period of time, because then if the patient is in a state of burst suppression for a prolonged period of time, they have a higher risk of developing post-op delirium. And that's what we want to avoid, especially in the elderly patients. Okay, so at the end of surgery, you want to be able to time your wake up. So why I also like this depth of anesthesia monitors is that they can show you when your patient is starting to wake up. So typically what you get when the patient is starting to wake up, you get what we call this unzipping pattern. So remember here we talked about the delta waves that you see and the alpha waves that you see. Here you start seeing what we call this unzipping. It's like a zip, opening up a zip, and this is what's happening. So remember with the previous one, everything was like straight. So you see everything is straight. You've got the delta and the alpha, everything is together. But now, when our patient is beginning to wake up, what we see, we get this opening up. We call this unzipping. And this typically occurs when the patient is starting to emerge from the anesthesia. We also see this sharp rise here, which is showing us that our PSI is going up and the patient is starting to wake up. We're also beginning to see a change in the waveforms here, where we are moving from lower amplitude, uh, higher amplitude rather, from higher amplitude to lower amplitude waveforms, from lower frequency to higher frequency waveforms. Okay, in this patient. What I often find is that once I get this unzipping happening, I time it with the surgery. So at this point, maybe I would switch off the volatile, and I know that I've got about 10 to 15 minutes for the patient to wake up, to completely be awake. And at that time, the surgeons are closing up the skin. So you can actually use your depth of anesthesia monitor to predict your wake up time. Okay, so this is just this patient. Okay. Then post-op, you want to consider a gentle lung recruitment procedure, because remember these patients are at a high risk of atelectasis. So you want to just recruit those lungs before you extubate. And once you've extubated the patient successfully, it's advisable to put the patient on nasal prongs or on supplemental oxygen, either via nasal prongs or a mask, because they're at high risk of desaturation. You want to avoid post-op delirium, as I said, and 40% of patients who develop post-op delirium will never return to their pre-op cognitive baseline. That's why it's extremely important to avoid giving them things like benzodiazepines, to avoid giving them ketamine, because that causes delirium, post-op delirium, and to avoid quote-unquote over-anesthetizing them, because then that will cause the patients to have develop post-op delirium. Okay, so in summary, as healthcare improves globally, it is projected that in 2050, about a third of the population in the developed world will be elderly. As anesthetists, it's important that we have a solid understanding of the normal physiology of aging so that we can administer safe anesthesia to these patients. It is important that elderly patients with chronic conditions presenting for elective surgery be optimized. An understanding of the pharmacokinetic and pharmacodynamic effects of commonly used anesthetic agents will help reduce pharmacologically induced perioperative complications. Post-op delirium needs to be avoided as it is associated with increased morbidity and mortality. Elderly patients should not be denied surgery simply because of their age, but rather a thorough clinical assessment and risk stratification process needs to be done to assist in clinical decision making. Thank you so much for listening to this talk. And most of the information that I've presented here is from the article on Up to Date, which I said was published this year. So if you want more information on this, go on to Up to Date, read that article on administering anesthesia to the elderly patient, and you will get a lot from that. Thank you. And if you've got any questions, please leave a comment there. we'll try and answer. And make sure you subscribe to this channel because we've got lots of content that's coming from our tutors who are helping us with tutorials here. And support this channel, help us to give safer anesthesia to our patients all over the world.